WZTS-LD 16 Hinton, Cozy TV.
Doc Talk with Dr. Paul Conley is a production of TTV, which is solely responsible for the content.
Hello, I'm Dr. Paul Conley, host of Doc Talk. Thanks for tuning in to another episode. And we're going to be talking about something called dysphonia. And what dysphonia actually means is what you're hearing right now, which means hoarseness of voice, raspiness, or basically any voice changes, and that's dysphonia. Dysphonia actually affects about 5.2 million Americans annually, with healthcare costs of $13.5 billion with the B annually. This actually puts dysphonia right up there with other conditions such as COPD, asthma, and diabetes. So here to talk to us about dysphonia and when do I need to have a laryngoscopy, and this is none other than Dr. Andrew Petersen. So Dr. Petersen, appreciate you so much. We're here in your office here in Fayetteville, West Virginia. And so I just really thought that dysphonia was something that we really wanted to talk about. And I'll be daggone if this weekend working around in the brush and everything if I don't have dysphonia for the episode. So my timing is impeccable.
Yeah, it's perfect timing. Happy to be on the show again. And you're correct. To have a little hoarseness yourself makes the episode interesting. Maybe we can dive in with our exam later today and maybe get to the bottom of it.
Well, absolutely. And one thing about you, Dr. Petersen, I love coming here to your office because you have so many cool gadgets and so many cool things. And you're exactly right. After our commercial break, you're actually going to dive down literally and take a look at my vocal cords and assess like what's making my voice so raspy. So really appreciate that. So
absolutely,
when we talk about dysphonia and we talk about flexible laryngoscopy, which you're going to demonstrate after the commercial, what exactly are some of the presenting symptoms that someone might have at home right now watching the show that would want to pick up the phone and make an appointment to come and see you?
Yeah, I mean, it's a broad topic in a sense because there's a lot of different symptoms that someone might present with. Just think anything that affects the throat or symptoms of the throat. So that could include hoarseness or changes in the voice, dysphonia, as you mentioned. It can also come in the form of dysphagia, trouble swallowing. It can also come in the form of just throat irritation or pain, that you have a sore throat to some capacity. And so, those are common presenters, as well as cough. That's another one that is worth mentioning as well. When we see patients for these presentations, there's kind of just two big picture jobs that we're doing. And that is, number one, to rule out bad, scary things, cancers, bad infections, really concerning healthcare presentations and pathologies. So we want to rule those things out. But then number two, we want to get to the bottom of your symptoms as well and help you feel better.
So we talk about presenting symptoms, hoarseness. So I guess for you, Dr. Petersen, as an ear, nose, and throat specialist, I just developed this hoarseness over the weekend. So you may say, well, that's something that, you don't necessarily need to see an ENT for. How long is someone like with hoarseness would alarm you that someone watching the show is like, yeah, that's long enough, you need to come in and see us?
Sure, yeah. We have guidelines that are, put out by our, national colleges that kind of provide guidance on some of these things that are available both to us as the ENT community, but also clinicians, across the board. And to answer that question, the guideline answer is 4 weeks. If you've had persistent hoarseness that is not resolving, 4 weeks is kind of the line where you should present to someone who has the ability to perform a flexible laryngoscopy to look and get a view of that area. And then the caveat is any time is the correct time to present if you have those symptoms along with any other suspicious symptoms, suspicious activity, severity, other symptoms and presentations that maybe raise the concern. Then it's appropriate to consider these exams at any point.
So dysphagia, you and I see a lot of the same patients in some ways. I'll find a patient with dysphagia and I'll do an endoscopy and it looks like they got something more that's an ear, nose, and throat issue, and vice versa. You'll see someone and send them to me because you think it's possibly more an esophageal issue. So dysphagia, when you talk about difficulty swallowing for the audience, when is that an alarm feature and what would concern you?
Sure. So, trouble swallowing, we can almost think of it as like different levels. Is it an oral problem where you're having trouble with the mouth, the tongue to like actually move the food to the back to swallow it? Is it something that's more in the neck, or is it something where you kind of feel it getting stuck, lower down in the chest almost? And that way you can kind of differentiate it into a laryngeal, pharyngeal pathology in the throat versus a esophageal pathology. And you're right, we do share a lot of these patients. It's a great opportunity for multidisciplinary team efforts, which we certainly share lots of patients. And some of our exams and endoscopy procedures that we perform, they have they're similar in ways, but they're also different. They have pros and cons as far as seeing all the way down into the esophagus, the stomach, the gastrointestinal system as you do, versus a laryngoscopy here in the office. We're basically going through the nose. We're looking at the voice box, the larynx, and the structures around it and up. So you can kind of use that as your differentiator of areas there.
Well, I know one of the things that we're going to do another episode upcoming, which is thyroid disorders, and I've had patients present to me with dysphagia and hoarseness, but it's all here, and on exam, they have a large thyroid or goiter, and I don't think people quite realize that if the thyroid is large enough, it can cause compressive symptoms, difficulty swallowing, but also there's a nerve that runs behind the thyroid, and if the thyroid presses on that, that can cause voice changes, right?
Absolutely, yeah. I think to answer the question of when to be concerned about dysphagia, it's similar to the hoarseness topic, which a lot of it's driven by severity and other confounding symptoms. If it's affecting your quality of life in a major way, losing weight, inability to eat certain foods, once you're losing capacity, that's a problem. And that you need to see a healthcare provider and begin the process of working that up. Compared to someone who, for the last 2 years, has had a little bit of thick mucus when they swallow, and they can feel it. It's a little bit clunky, but all the food goes down just fine. Those are two separate categories in my mind.
In sore throat, I've seen some patients that present to me and they've been on 2 or 3 rounds of antibiotics and they still have a sore throat. At that point, that's probably something of concern, because if it was something as simple as strep throat, after 2 or 3 courses of antibiotics, they shouldn't still have a sore throat.
Sure. That is, it almost kind of harkens back to our rhinology episode that we did, where it gets to the topic of mucosal health. Sore throat kind of encompasses all forms of throat irritation, sore throat, throat pain, but it can be, a lesser severe symptom as well. And it's back to the, why would you have that? It often has to do with mucosal health. Are we hydrated? Are we getting excess nasal drainage from above, irritating the throat? Are we getting excess stomach acid and reflux irritation from below? Are we breathing things on a daily basis through our work, occupational or exposure irritants that irritate the throat? One that folks forget about or don't think about would be mechanical irritation, essentially in the form of snoring. There's other examples, but snoring is the best example. That is mechanical irritation all night long, irritating the throat. You wake up, you got a little bit of a sore throat in the morning, and it can be severe and impactful for some folks. And that's one that's often missed. But mucosal health, mucosal irritation is definitely a common topic for us to talk about here. Again, that's not something that is life-threatening, and it's also not something that we need antibiotics for. It's usually the fix to that is to identify the problem, identify what the irritant is, and address it in that way.
So when thinking about causes, I know you kind of hit on these, and maybe we could talk a little bit about treatments, but nasal drainage, I think about post-nasal drip causing hoarseness, the reflux, the ENT world, you use the term LPR,
Yep.
mucosal dehydration. So maybe you can kind of walk us through some of the most common causes of dysphonia.
You know, it's. I think I said it in the last episode. It's to be the best provider, clinician, to give patients the best outcomes, whether that's surgical, medical management. For me to be the best provider, I need to be the best clinician. So you got to figure out what is the problem, and then you can find your solution. And the list you just went through there, I would say that is the most common, between nasal drainage, reflux irritation from below, mucosal dehydration, not enough water, too much caffeine, side effect from medications, which is very common, mechanical irritation like snoring we mentioned, and then one we can't forget is smoking. I mean, that's a giant irritant to the mucosa as well. I'd say that list right there encompasses the majority. Notice what's not in that list are cancers. Now, we're always wanting to identify, like I said, rule out the bad, scary pathologies, make sure it isn't a cancer. It usually is not, but that's not something we're willing to be wrong about. So that's where our flexible laryngoscopy comes into play. Make sure it's not something more concerning. Find clues to what it is the problem, and then dive into our treatment plan.
I know for me, when I see a patient who's a smoker and they have dysphagia and change of voice, that really raises a red flag to me, because it's alarming. Because you always remember some of the bad cases, right? And I remember a patient that was referred to me who was having sore throat and dysphagia and weight loss, and they were a smoker, and they had a huge cancer of the tonsil, HPV related, and they had been basically treated with antibiotics, and basically when I did the scope, no more than I passed the scope, you could see the mass. And so unfortunately, this individual was a smoker. And I know when it comes to dysphagia, if I see again a patient who's having difficulty swallowing, and if they're having any weight loss, I mean, that's an automatic endoscopy. That's an automatic assess, because you have to rule out a malignancy causing the inability to swallow, because there could be a growth, a mass lesion sitting right there.
And I'll say too, we're talking about these symptoms individually, hoarseness, dysphagia, sore throat. When you start blending them together in a single presentation, that raises concern. Hoarseness of voice, smoking status, and now we're having trouble swallowing. Maybe we've coughed up a little blood. You start adding together symptoms, that raises the concern, compared to speaking of these symptoms in isolation.
So before the break, we got a little bit of time. One of the things that we talked about before was a couple other things. You're talking about irritants and occupational exposures, but you also mentioned to me vocal cord paralysis, and you used the word neurologic causing the hoarseness of voice. Maybe you can explain what that exactly means.
Sure. I mean, that's its own kind of dedicated category. Vocal cord paralysis means that the nerve that supplies the vocal cords, or one single-sided vocal cord, has quit working. And in an ENT clinic, it's unfortunately a fairly common presentation. It occurs for a list of reasons. It can be secondary to surgeries as a side effect there. It can also happen after viruses and colds that we get. There's the concept of post-viral vocal cord paralysis, which is certainly the most common. Again, it's back to the concept of we want to rule out the bad diagnoses. We want to treat your symptoms. There's procedures, surgeries, and therapies we offer for vocal cord paralysis. But that's always something that we're wanting to rule in or out.
Well, it looks like we're coming up against the break. So what we're going to do, folks, is we're going to take a quick commercial break. You're not going to want to miss this, so stay tuned, because when we come back, Dr. Petersen is going to actually perform an examination, a laryngoscopy right here. So again, commercial break. Stay tuned, and we'll be right back.
You're watching Doc Talk with Dr. Paul Conley on WZTS 16 Cozy TV. Stay with us. We'll be right back after these messages.
Vandalia Health is proud to be a West Virginia-owned healthcare system, bringing together the hospitals and providers of CAMC, Mon, and Davis. We are dedicated to enhancing the health of our communities through clinical excellence. Our compassion and commitment remain the same with people you know and trust to care for you and your families. With more specialists, hospitals, and outpatient locations, we are delivering expertise and state-of-the-art care. Vandalia Health, expert care close to home.
Welcome back. Doc Talk with Dr. Paul Conley continues on WZTS 16 Cozy TV.
Welcome back to Doc Talk. I'm Dr. Paul Conley, and I'm here tonight with Dr. Andrew Petersen. We are here in his office here in Fayetteville, West Virginia. We've been talking about dysphonia, which is what I'm experiencing right now, which is hoarseness of voice, raspiness, or basically voice changes. And we talked about some of the symptoms of hoarseness, dysphagia, which means difficulty swallowing, or sore throat for any length of time that's somewhat concerning. You would want to talk to your primary care doctor and see Dr. Petersen. And one of the things that we talked about at the break is this term called flexible laryngoscopy. And so Dr. Petersen is going to talk about when do I need a flexible laryngoscopy. And that's a big medical word. Anytime I see the word scope in there, I understand that obviously it must have something to do with the scope.
Sure, yeah. So flexible laryngoscopy, common procedure performed here in the ENT clinic. It's another example where we get the benefit of lots of tools and as you said earlier, gadgets that help us to do our job. And in the world of ENT, there's a lot of part of the exam and a lot of the anatomy that is it's just flat out not easy to see without using a camera or a scope of some sort. Last episode, we demonstrated a rigid nasal endoscope for nasal and sinus purposes, and today we're going to demonstrate a flexible laryngoscope, and it's the same concept. It goes onto a camera displayed on a monitor over to the side, and but it's with a flexible camera this time, so it can kind of wiggle through the nose to then see the back of the nose, turn the corner to look down towards the voice box, the pharynx, the throat, all the way up to kind of where the esophagus begins is kind of the target of that. People ask all the time, does it hurt? How does it feel? I mean, we easily do, 10 to 15 of these exams a day, all ages, children to adults. It's pretty well tolerated. We spray a little bit of Afrin, which is a decongestant to help open up the nose, also mixed with a little bit of lidocaine to help numb slightly, to help the exam be more comfortable. I usually describe it to patients as being like a nasal, like a COVID swab, only better.
Thank goodness.
Yeah.
Because I've had the COVID swab.
With those nasal swabs, they're in there trying to touch on the various structures to get a collection. With this, I'm driving the camera, trying to avoid bumping into the various structures so it's comfortable, but also so that we can get to where it is and see what we need to see.
I'm glad to hear that, because one of the worst Doc Talk episodes I ever did was Dr. Anita Stewart, and that was when COVID first came out. As a health officer, the original initial COVID swabs.
It's not fun. It's not fun, yeah.
And also, we talked at the break too, Dr. Petersen. I'm just going to kind of go back as a history lesson. When I was a resident, one of my good friends was
Keep talking. I'm going to start getting
specialist, and he literally took a gauze like this and would pull your tongue out with the gauze. So the gauze would basically, so you could hold into the person's tongue, and then take the little dental mirror and hold it in the back of your throat. And somehow as you're pulling the tongue out of me, the patient, and then you're trying to make me say, oh, I'm putting that mirror. I literally don't even know if he even saw anything, but that's how draconian, barbaric it was back in the day.
mean, yeah.
So think about how you're going to able to do this with the scope and how far we've come to be able to do this right here in your office is quite impressive.
You use the tools that you have available, and luckily we are in a modern era of medicine with lots of exciting pieces that come with that. And you're right, that those dental exams, while effective for some, ineffective for others, I don't even have that equipment. If I need to take a look at your larynx, your vocal cords, I'm going to use a flexible laryngoscopy, as we're going to show.
Why would you have that piece of equipment, right? I mean, it's kind of like horse and buggy. I'm sure you don't have that either. So,
all right.
But that was impressive, that you can do this versus pulling my tongue out with a mirror.
All right. I'm going to spray your nose. This is our Afrin lidocaine mix. As we said before, I gave you a tissue. You don't need to do anything. 1, 2, 3. 1, 2, 3. Good. Now, just a gentle sniff in. I don't want you to blow your nose. We want that medicine to stay in there and work a little bit. It does not make it completely pain-free or completely 100% numb. I'm going to reach across you here. Excuse me.
You just tell me where I need to be.
Okay, you just hang out. Why don't you tell us a little bit about the hoarseness that you've been having, you said over the weekend, is that correct?
Yeah, so, it's one of those things where you're out in the brush. I was doing some brush hogging, trying to clear out my garden, to restart my garden, just doing stuff from the leaves and what have you. And then then I just kind of woke up this morning and my voice was hoarse, and I thought, because you talked about this show a week or two ago. It's like, hey, you want to do a show? And you're like, yeah, let's talk about hoarseness. And I thought, well, here you go.
Yeah, so that's
spot on.
That sounds kind of, that would make me think about, again, an exposure, irritant, allergy, or just particulate from, working in the brush. Do you feel like you're getting sick at all with a cold type symptoms?
I could, but I don't know, I'm here at work and everything else, scope today, but
you don't seem sick to me at the moment, so I would still kind of hold that irritant exposure as the most likely thing. All right, so here's our flexible scope as we talked about. You can see it moves. It's a flexible scope. The whole thing does not go in the nose, usually kind of about to where my fingers are right here. It's going to be up on the screen, so you can just kind of lean back, use the headrest, flexible scope in the nose. You breathe easy through your nose or your mouth, whatever's most comfortable for you. Once I get in, I'll ask you to do a few different commands, like stick your tongue out, say E, things like that.
So maybe you can even tell the audience, and myself included, like, what you would see that would make you think it's, reflux, the LPR, maybe explain LPR, because that's where we kind of see the same patients versus postnasal drainage, and maybe what nuances or differences you may or may not see. Hopefully you don't find a lesion or something on my vocal cord, but that's also something we talked about.
We're ruling out bad things like we talked about. All right, we're recording this so we can review later. So here we go. We're going to peek in the nose. I know from our previous exam, this is your better side. Your septum deviates to your left a little bit. And so we're looking at your septum on the right, your turbinates on the left. So we're going to kind of wiggle through this space here. This is usually the most uncomfortable part of the exam, just getting to the back of the nose. So here we are in the nasopharynx. We've got the eustachian tube on the side, kind of looking where your adenoids are. And you've got a little bit of white drainage here, thicker drainage. Again, could be reactive to your work over the weekend. You might be getting sick. I guess we'll tell over the next few days. Here we are looking at the back of your tongue, the epiglottis, big cartilage structure that's right here. Why don't you stick your tongue out at us for a moment? That allows me to see kind of in behind that space. Good. I'm going to clean the camera. That's great. You can bring your tongue back in. Now I'm going down, I'm looking at your vocal cords. Sometimes can make you cough. I'll try not to make that happen. Let me hear you say E.
E.
Good. That's great. Big sniff in. Great. Let me hear you say E.
E.
Good. Just breathe normal now, just in and out. So we're seeing your vocal cords. They move well. You don't have a vocal cord paralysis. I'm going to get close a little bit here. You just breathe normal in and out. If you cough, I'm sorry. Give me a gentle sniff in. Yeah. I do see a little bit of irritation of your vocal cords. It's not bad. There's nothing of high concern. Again, I think this could be attributed to the irritants over the weekend, and who knows if you got a little virus. The next day or so would tell. Last time, let's hear you say E, just to show the vocal cords move, and then a big sniff in. So you can see the vocal cords come together when we speak. They open up when we breathe. They're dynamic structures moving the whole time. And that looks great. Okay, coming out of there. I'm going to stop recording. So normally at this point is when I'm telling patients the good news of that there was nothing bad. I did not see any lumps, bumps, growths, tumors, cancers, weird infections is often how I phrase it to patients. So that's great. Let me just set this over here for a moment. You feel okay?
That actually wasn't that bad. Actually, it didn't really bother me.
And I was taking my time for kind of demonstration purposes there as well. The typical exam, I think, is in the 15 to 30 second range. But yeah, that went smooth and well. Everything, like I said, no bad pathology.
So what would be bad pathology? Since, thank goodness I didn't have anything bad, what would you be able to see by doing this exam? Vocal cord polyps, lesions, like what all?
Yeah, so potentially a growth or a tumor somewhere. So it could be on the vocal cords themselves, and not all tumors are cancers. There are benign growths that we see. And then, of course, there's more concerning ones, and they each have their own different appearance, but it would be a physical growth, tumor, ulcer, cyst, polyp you mentioned. Those are generally associated with smoking. So to see a physical growth of that manner. But we're not only focusing on the vocal cords. We're looking up above. We're looking at the all of the structures as well above the vocal cords, and those can also have tumors, infections with them. Those are kind of the high points. We're looking to see that the vocal cords are both moving properly, as we mentioned.
So if that was that neurologic condition, vocal cord paralysis, when I did the E, what would you see in vocal cord paralysis?
Only one side would move. So we would see one side of the one vocal cord opening and closing, while the other side just stays static and stays still. And the problem with that is you can't close your larynx. You can't close your airway. It leads to weak voice, easy aspiration, easy coughing and choking, and a list of things. We have procedures for how we can address that. There's procedures to inject material behind that vocal cord and move it over so that the functioning cord can reach it easily. And then there's permanent versions of that surgery as well too.
I've seen some patients in my practice who have had a neck surgery where the neurosurgeon would go through an anterior approach to treat, let's say, a disc in the neck, but in doing so could cause some hoarseness of voice afterwards.
I've seen patients with hoarseness after such procedures.
One thing, again, let's talk about the thing that we see a lot of in this country, and I see it all the time, which is reflux. So tell me again, if you can, this term LPR, what does LPR mean? And what would you see on a laryngoscopy that would then make you suspect the patient has LPR?
So LPR, laryngopharyngeal reflux, it's kind of the ENT term for reflux affecting the upper airway or the larynx. Another term for that is silent reflux, and that's kind of comes about where people can have reflux that is causing symptoms in the upper airway without it being severe enough to get classic heartburn. So it's kind of upper airway symptoms without traditional heartburn symptoms. And then on the laryngoscopy, we would see swelling behind the vocal cords near the opening to the esophagus. You can see swelling in that area. That occurs because of a few different mechanisms. That's the key finding. There are others that you can see as well.
Yeah, I do think that a lot of people that have acid reflux, they think that you have to have heartburn, but you and I both know that you can have acid reflux and it can either be hoarseness of voice, sometimes cough, especially when you lay down at night. And so I know you and I a lot of times will have these individuals that they have hoarseness of voice, and you'll do an examination and you say it's reflux, and I do an upper endoscopy and they have horrible esophagitis downstream that you can't necessarily see on this exam.
Sure, absolutely, yeah.
Well, we're down to like 20 seconds, so Dr. Petersen, I really appreciate you again. We're talking about dysphonia. We've been talking about hoarseness of voice, and we've been right here in Dr. Petersen's office here in Fayetteville, West Virginia. So again, hoarseness, dysphagia, sore throat, all encompasses with dysphonia. If you have any of those symptoms, and again, if they've been going on for over 4 weeks, contact your doctor and come in and see Dr. Petersen, and he can do an exam just like me right here on the big screen. So I'm Dr. Paul Conley, and you've been watching Doc Talk. Until next time, have a good night.